Well, thank you for that introduction. Yeah, I cover all things climate. I also had a stint as a health reporter nearly a decade ago, which is why I'm especially thrilled to be moderating this session on decarbonization in the health sector. There are many ways in which climate and health intersect: the changing geography of disease, the health impacts of heat, the list goes on. But there's also the enormous footprint that the health sector has, 8% of US emissions. And luckily, or for better, there is a emerging conversation about what to do about that. And so I'm thrilled to have these three excellent panelists here to talk about that. We have Shanda Demorest, and I'm sorry, I know that I butchered your name, a doctor of nursing practice and associate director at climate engagement and education at Healthcare Without Harm and Practice Green Health. Seema Gandhi, as anesthesiologist and medical director of sustainability at UCSF Health, and Jeff Thompson, former CEO of Gunderson Health Systems, and I believe a pediatrician. Is that right?
That's true.
Okay. So I want to start, instead of a formal introduction, to just go through and ask you each about the case for the health sector to take on climate. One thing I hear talking to people in health is, you've got a mission, which is saving lives, and that's really important. How do you make the case that this is something that the health sector needs to take on, one, and then two, what are you doing to advance that cause? And I think maybe we'll start here with you, Seema, talking a bit about, what's happening at a hospital level, at an OR level.
Excellent. First of all, thank you, Aspen. And it's very exciting to be here, because working in this space for about 10 years, to see people who are a part of the problem and also a part of the solution in the same room or the same tent is very exciting. So thank you very much in bringing these conversations to forefront. A little bit of background so you have a context of how my journey started is born and raised. I grew up in India, but I'm also a board certified anesthesiologist from India. And then married to my knight in shining armor, I practiced anesthesia for 5 years in the UK. And as most of you know, the National Health Services is the biggest public health sector. And then fast forward 15 years, I've been at University of California, San Francisco, where now I am the medical director of sustainability for the health system. And sort of working in 3 continents, I needed the practice, but working in 3 continents, what really sort of struck out to me at UCSF and in North America was sort of our policies and our practices that led to waste and led to sort of emissions and increased cost. But that coupled with, there wasn't as much awareness, and today we're here talking about these issues, but when I started about 8 to 10 years ago, just talking to my anesthesia providers about anesthesia gases, and these are potent greenhouse gases, and some of them stay in the environment for up to 100 years, and ask my colleagues about it, and they're like, I don't know. So sort of that really started my journey. And I started more as an anesthesiologist in the operating room, focused on anesthesia gases, and that sort of movement has now expanded across the University of California health system. And just this morning, I was at a conference, a Zoom conference with IHI. So there are a lot of other health systems in the country that want to do it. Specifically, the big things that I focused on was education, research, and mitigation efforts. And we'll get back to some of this again, but my work really focused on decreasing the consumption, the waste focused on anesthesia gases and the solid waste. And my work has always been upstream, and I think that's a theme we'll talk about during this conversation.
Great. Well, Shanda, I'd love to go to you next. Thinking maybe at sort of a health systems, or excuse me, a hospital systems level, but just how you work on these issues.
Great, thank you for that question. And Seema, I'd like to underscore your appreciation for Aspen. Super great to be here and to be amongst friends. So I'd like to start with making the case. The case is that the climate crisis is a health crisis. And as the healthcare sector, not only in the United States, but internationally, our mission is to do no harm. So even extrapolating this beyond climate, as if that weren't enough, there are many ways that healthcare is damaging our environment, from chemicals to pharmaceuticals to our relationship with the agricultural sector. And these emissions and the toxins and all of these exposures impact public health, but also impact individual patient health at the bedside. I started as a nurse by background, practicing cardiovascular in Minneapolis, Minnesota. And I took care of patients with heart failure, patients with transplants, patients with artificial hearts who experienced worse impacts on days with poor air quality, who experienced worse health on extremely hot days. I was seeing the health impacts of climate change at the bedside. So we need to be creative in the ways that we're thinking about how to deliver on our mission as a healthcare sector. The way that I get to do that is working with Healthcare Without Harm. So as Seema referenced, there are entities out there, which is so exciting, that are focused directly on the public health impacts of the climate crisis and our environmental impact in the sector more broadly. So we work with about 1,600 hospitals across the country that are part of our Practice Green Health partnership. And they are addressing environmental sustainability from everything related to waste reduction, to chemicals, to food, transportation, water quality, and of course, greenhouse gas emissions, which I know we'll talk a lot about more. The last thing I want to mention, since I'm hanging on this decarbonization phrase that's right in the title of our session. When we think about greenhouse gas emissions, carbon dioxide comes to mind. And I want to encourage us as we're having this conversation to think about all of the other greenhouse gas emissions that aren't carbon dioxide. Methane, we'll get into some of the waste anesthetic gases, sulfur hexafluoride, some refrigerants. There are a lot of nasty ones out there. So as we're talking today, make sure that we think about decarbonization more broadly related to all greenhouse gas emissions from the health sector.
It's a very important point. Jeff, to you, I'd love to hear your thoughts on this question, particularly on the big macro picture, policy changes, et cetera, but love to hear how you're working on those things in the big picture.
Thanks. So the way I think about it, and the way I encourage small, medium, and large international organizations to think about it, to start with, is that pollution kills people. We have tons of data that pollution kills people, and all the greenhouse gases and all the things we say, but pollution kills people. There's great data. The Harvard study came out last year. 30,000 plus Americans die every year because of the pollution. Healthcare contributes to that. Pharma contributes to that. I mean, we contribute to that, and it makes my asthmatic patients sick. It makes old people with COPD sick. So our pollution kills people. So that's the starter. And if you can't get excited about that, then you're probably in the wrong business. But we have to take ownership of that and say that's where we start. Do I believe in climate change? Psh, absolutely. But our approach from the start, and we started working on this at Gunderson in 2008 and 9, was not about climate change, because our board wouldn't have allowed us to work on climate change. But we said, if we can decrease pollution that's making our people sick, if we can save money, has always been referenced here a number of times, and if we can improve the local economy, is that okay? And the board says, well, yes, it's okay, but you can't do it. I mean, it's impossible. But we did it. We did it so well that by 2014, we had days where we were 100% heated, powered, and cooled by renewables that we owned, and had dropped our greenhouse gases 95%. So you can't tell me it's impossible. We're making money, lowering the cost of care, improving the local economy, and because of that, I was invited to the Paris climate talks as the only U.S. provider to speak there, because everybody else was making promises. We already had results. Fabulous team of people, a great community, but they're committed to the immediate. We have to decrease our impact on the health and well-being of people. That theme is now spread broadly, and I'll spend some time later talking about it, but there are now large healthcare organizations that have been mentioned, societies, manufacturers, even petroleum companies that have said, we will change. So the momentum, the optimism, remarkably different than a decade ago.
Great. Well, that's a great way to lay the groundwork, and of course we'll come to audience questions at the end, so please be thinking about those. I want to just hone in on something that came up, I think, in all of your remarks to some degree, which is, you know, the opportunity to save money, the cost. I think a lot of people, a lot of businesses, when they hear, you know, decarbonization, they think this is going to cost money, and I'm sure that's the same in the health sector. So I'd love to hear from each of you how you think about these costs. How do you show that actually it can save money? And maybe we'll start again from an operating room level, and then we'll go big picture.
Thank you, Justin. And so most of you probably know, and this is why cost is so important to talk about, is US healthcare is the most expensive healthcare in the world. Comparing ourselves to our high-income peers, right? So we're not comparing US healthcare to India, but we're comparing US healthcare to France and UK and other high-income peers. We have the worst outcomes. So that is what that's the question we have to ask ourselves is, we have the worst outcomes, we have the most cost. There is an opportunity here. We can provide the same quality of care at a lot lower cost. And for me, that sort of practically how that happened was, I always say I have two pitches. I have one pitch when I go to the C-suite. I usually take my cost pitch to them. And then I have another pitch when I talk about emissions in a group like this. So we noted, and I want to give two specific examples, and especially anesthesia gases, because they're forefront and center right now, is I compared the choices that we make in US versus my practice in the UK. And I found that, the choice of the gas. In US, we used the most expensive anesthesia gas without commensurate clinical benefits. And second, the same gas we used at a lot higher amount. And so I started questioning, I'm like, why are we doing this? Why are we using desflurane, that's the gas, and why are we using it at 2 liters, right? Just remember those numbers, desflurane and 2 liters. While as in the UK, they use the same gas at 0.5 liters, which is, multi-fold less than what was used here. And this brings me to the question of policy. Due to some non-evidence-based policy made decades of years ago, the FDA had mandated that this gas be used at 2 liters, and we can talk more about it. So we started educating our providers. We made a business case of, if we decrease the flows, how much money can we save? And then we also looked at the carbon impact of it. With that, we were able to show just with one desflurane gas, we eliminated it, and we saved about $300,000 just in 1 year. And just yesterday, nitrous oxide, which will really be talked about a lot, we were able to pull the pipes of nitrous oxide from our entire health system. And we expect to save about 2.6 million miles of cars driven.
Wow.
Wow.
So yes, at grassroots, that's how we tackled it.
That's great. I'd be curious, Shanda, how you think about these conversations with health systems, with hospitals.
Mm-hmm. This is why I brought my notebook. I have real data written in here. So with our practice green health partners, of which UCSF and the full University of California Health System is part of, Gunderson, each year we hold what are called the Environmental Excellence Awards. Hundreds of hospitals submit data on all of their environmental sustainability programming, and we ask them to add the dollar sign. How much are you saving? So we had some excellent examples from desflurane savings, but we ask across the board. Here are a few examples that can be achieved annually for health systems in a variety of opportunities. So related to energy efficiency in the operating room with heating, ventilation, air control modulation. Facilities are saving $30,000 a year. If we're looking at single-use devices, so transitioning away from the plastic materials that we use once and chuck in the trash, almost $100,000 saved per facility annually. Another example, switching from gowns that we dispose of. We think of COVID-19 pandemic and all of the isolation gowns and the personal protective equipment that nurses and providers were using to take care of patients. Almost $26,000 saved a year. And that's a resilience measure as well. I'll hang on the resilience term as another vocab piece to throw out here in our climate action conversation, because I think that has some substantial financial benefits that we don't quite know how to quantify yet, but those are the metrics of the future ultimately. When we talk about climate resilience, we're looking at making our facilities, our public infrastructure, and even our communities more resilient to the climate impacts that they're going to experience now and in the future. So if health systems are more resilient to flooding, to extreme heat, to droughts and hurricanes and tornadoes and wildfires, they're going to be able to keep their doors open during those climate catastrophes. They're not going to have as many issues to the infrastructure that they'll need to deal with post-climate event. So unfortunately, we have more and more case studies related to how climate resilience is saving money in the future, or saving money for health systems. And both of those things, hand in hand, climate mitigation and resilience are definitely beneficial for that bottom line. And all of this being said, taking climate action cannot be driven from the business case alone.
So I'm curious to hear, Seema, you mentioned policy barriers and some of the challenges with regard to policy. I'd be curious to hear a bit about what those challenges are, what the fixes are, where you're maybe seeing movement, and maybe we'll start with Jeff and then we'll get some others in.
Yes, I think there's many opportunities for that. I think when you look at the big scale, something that goes across all organizations in all places, for example, you take waste. It's easy to demonize waste rather than any one thing or any one person. So you demonize the waste and say wasted energy. Well, not too many nurses and doctors really care about the energy company at the end of the wire. So decreasing energy costs. Now you go across systems, you take all the United States and all the healthcare organizations and you drop our energy use by 10% in a year. It's not that big, but it's a lot. There's over 1,000 organizations signed on to the pledge to drop their greenhouse gases by 50% by 2030. That organizational effort, when you start signaling things like that.
Can you just identify what that pledge is for everybody, so that they know?
Yeah, there's the Health and Human Services has asked about a climate pledge, and over 1,000 have signed on to it. If you take all the waste from pharmaceuticals, studies are 30 to 50% of pharmaceuticals produced are wasted. So if you start signaling, we're not going to waste this anymore, pharmaceuticals companies start changing how they behave, suppliers start changing how they behave. Food waste. What percentage of the food in this country is wasted? We have children going hungry every night to bed. We waste 40 or 50% of our food stuff. So you start doing things like that. Then there's other policy things. Seema was talking about evidence-based. There's rules that were made on how many air exchanges you need in certain environments in a hospital. And the rules were set on guesses, not hard science. And so there's fans running 24/7, exchanging the whole air in a room 14 times an hour. Unnecessary. No data, no evidence to say that's what works. And that goes across whole states or sometimes across the whole country. Building supplies. I mean, just here's an example on how struggly it is for organizations. California has certain laws. Wisconsin, Iowa, Minnesota have certain laws. The furniture that you put in a hospital in California would be illegal in the upper Midwest.
Right.
But if you took the furniture from Wisconsin, you put it in California, you would get cited and fined because it's illegal, because of policy inconsistency on a variety of chemicals.
So there's a need for sort of a different policy architecture. I don't know, Shanda, do you have any thoughts or examples about places where you're seeing policies that are helping evolve here?
Yeah, thank you. So we're seeing the systems that have built structure, governance, budgeting, finance, staffing, charters, that infrastructure for longitudinal sustainability and climate action is critical for success. And historically, we've seen grassroots action from physicians and nurses like myself saying, I'd love to recycle. Can I do a little bit more to reduce my own personal impact of being a health provider? That's not the way we can address this anymore. And so systems that have folks at a director level or even a C-suite level that have responsibility and accountability for keeping track of metrics and reporting even up to the board are those systems that are most successful.
Yeah,
Thank you, Justin. And I want to take my time for this question because I think policy and all of us working together is so important. So usually when I frame a lot of the problems, I have this construct of A, B, C, D. And A is really sort of awareness, education, accountability, all of us working together. And I think in each of those areas, there needs to be some focus on policy, right? Our education bodies can say core competencies in medical schools, health professional schools should include something about climate change and sustainability, right? So we can start with education. At an institutional level, there are some policies that we looked at, haven't been looked at for 30 or 40 years. Science has moved on. So I think creating policies to hold each other accountable is very important. B is basing decisions based on science. Now, I gave you one example, sevoflurane, the anesthesia gas. Australia, Germany, France, UK, all of those countries use the gas as 0.5 liters. While we are limited by our policy and our regulatory bodies that ask us to use this gas at 2 liters. Mind you, we just published a paper right now. We're not doing it at 2 liters. And this is taken into account millions of cases. There hasn't been a single case done here. The only studies were done in mice models. So again, basing our sort of evidence basing our decisions on evidence. And then C is, this is where policy is going to be important, is collaborating, right? A physician cannot do it on their own. A nurse cannot do it. But when you get the policymakers, the regulators, the pharma companies, there are some great pharma companies out there who want to do the right thing. And their answer is, my God, there's so much policy and red tape around it. Status quo is easier, right? And then the last thing is D. And I think that's the most important part. Do. We all know what the problem is. There is some great movement at NAM, at HHS. I think we all just need to start doing at personal levels and at a professional level, right? So all of you sitting in the audience, there's small changes you can make in your personal lives that will translate, including self-care, investing in your health, that just keeps us out of the hospitals.
I want to follow up and sort of do the sort of tough journalist question here, sorry. But just to ask, okay, so we're talking about policies. You said they need to be, evidence-based, and presumably there are some that aren't, that you identified. Where do we need to see those changes? I mean, what are the agencies? Are there particular policies that are really galling? Just, if you could name a few, we don't have to go too deep, but be curious.
I don't know if there are policy or regulators in the room, but I would say that policies at a departmental level and institutional level, but the big ones, right, with the big sort of roles comes big responsibilities. So I would start with the Joint Commission, right? And I know that John Worland has put environmental sustainability sort of among his 3 top metrics, but I think the Joint Commission is really big. CMS, right? Incentivizing people for the right behavior. I think they have a big part to play. Manufacturers, and so governed by the FDA.
Right.
Because we're getting into this epidemic of single-use devices, which is not evidence-based. So I think policy and governance there. And another one I want to point out is pharma, right? Because, there's so much drugs that were wasted, and insulin is one classic example, while as we know that patients are dying for lack of insulin. So where we can split drugs, make pre-filled syringes, arbitrary expiration dates. So I said, the C is collaboratively, all of our working together is going to be extremely important.
So you're talking about a really big system change, which is a good segue to my next question. We have this big number, 8% of US emissions are coming from the healthcare sector, but the majority of that is not in hospitals or in the operating room. There's the whole supply chain, there's all the other folks who are participating in getting to that number. So I guess I'm curious, what's the best way to facilitate that big system change beyond just the hospital level? And maybe we'll start with Jeff and we can come around.
Yeah, I think that's really important, Justin. People really don't understand where the biggest carbon footprint is, in fact, all the things that we buy and make. And actually, personally, we want to start making changes. That's a place we can all make some changes as well. That is a huge footprint. And so I think a number of organizations been mentioned. The Joint Commission's been mentioned. They certify, signaling that they're heading in this direction is very important. That's good. Institute for Healthcare Improvement's the largest quality improvement organization in the world. They're signaling this is an important part. It's part of improving the health and well-being of populations. Another example I'm going to use for many of you that looked at the schedule earlier, the person that was supposed to be in this chair is Dr. Victor Zhao. He's the head of the National Academy of Medicine. National Academy of Medicine was formed by Abraham Lincoln quite a while ago, it turns out, and to do research and convene experts to improve on the health and well-being of people. And it's been doing that ever since. And as an example, for this topic, they've put together a grand challenge. That's what Victor is going to talk about, his notes. And the grand challenge is convening all these people that we already talked about, and people from HHS in the government, people from the private sector, insurers, and manufacturers and distributors. And there's over 70 of us on the initial group of gathering that are then divided into health policy experts to say, what health policies can we advance as a collaborative group? What educational pieces need to be put in the educational programs across nursing and physicians to make this better? What can we do with the supply chain? What issues can we work together and say, these are short, these are long, and these are intermediate things that we can do right away? So this group has been gathering for almost a couple years. It's planned to go on more. It has received a great deal of momentum. It came at a perfect time where 10 years ago, if you'd have tried to do this, it had been a small group of us. But now there is a very large group of very engaged leaders from multiple sectors. So this is encouraging. And then when you turn, you don't have to all go up to Washington and lobby. They're in the room. The agencies are in the room, and they're interested, and they know this is about the health and well-being of people. So we're making good traction at good speed.
So you're talking about public-private partnership, getting everyone in the same room to agree on the destination. Just to take it, maybe one level deeper. What sort of things would you hope would emerge from those kinds of conversations?
Well, I think the things to emerge would be people agree on where we're going, as you pointed out, but then take the next step and say, what are the most likely things that we could do, systems, pharma, and the distributors, to decrease this pharmaceutical waste we were talking about? What can we do to educate people, to change packaging? What can we agree on doing right away to start making a difference, and what's going to be intermediate? So you can do that. What policy things can we as a group, if you take that group that I just named and sit down with leading senators and congressmen and say, we all agree, we're all going to take a little beating on this, we're not as good as we need to be, we understand, but we agree. This is one of the great powers of the National Academy of Medicine. It is a convener of multiple people from different points of view, and the power of that convening results in recommendations, actions, connections that then spur other actions. It is those things that make it such a powerful event.
Do you mind if I jump in there too? So if you don't happen to be in a leadership position that's at a table like Dr. Thompson's referencing, there are still critical roles that folks in healthcare can already be playing. And frankly, there are conservation and efficiency measures that have been around for decades that can be saving energy utilized in health systems. So for example, on the supply chain riff, folks can be using fewer supplies and materials to take care of patients at the bedside in the first place, being really mindful about what we're bringing into the patient room, being really mindful about the supplies that we're pulling from that from the desk in the first place. From an energy perspective, how can we titrate what's used to heat and ventilate facilities? How can we reduce the amount of time that computers and other electronics are on? How can we be much more conservative about lighting? Even things like our MRI and other radiology equipment are really energy intensive, and there are behaviors and practices that we can be instituting 20 years ago that will also move us forward in the path to reduce greenhouse gas emissions.
Exactly.
I just wanted to, so Justin mentioned 8%. 8% of our national emissions are attributed to healthcare. Now let me put that in context. The rest of the world, about 4.5% of national emissions come from healthcare. So you start seeing the theme here, right? US is an outlier. We're the most expensive, we're the most polluting, and we have the worst outcomes. So the way I look at it is we have a lot of opportunity to work, right? And then a couple times the word supply chain was mentioned. So I wanted to put that in context is where are these emissions coming from, Justin? And when we look at, and these are again national emissions, not individual hospitals. We are attempting to take that on with the support of Commonwealth to find out what the emissions from the University of California system is. But for now, we have data on national emissions. And 8% of emissions come from scopes, and I don't want to complicate it too much, but emissions are divided in 3 categories: Scope 1, Scope 2, and Scope 3. Scope 1 is the emissions that come directly from your hospital. So if you use boilers, if you use backup generators, if you use gasoline for your cars and fleets, anesthesia gases, refrigerants, those that come directly from the hospital is Scope 1. Right now, 7% of US emissions come from Scope 1. 11% comes from purchased energy because we need, a lot of energy to run these institutions. So that's 11%. But guys, 80% of the emissions come from the stuff and the services that we're using. Transportation, food, medical supplies, devices, pharmaceuticals, disposable of all the devices that we use, patient travel. So a lot of the stuff all comes in 80%. So I could build the greenest electric hospital, but till we don't work together to look at that 80% and supply chain, I think that we will not get to our net zero goals. And I just want to echo what was said here about the targets that we've set. And the National Academy of Medicine, and now what is popularly called as the Climate Pledge, is decreasing healthcare emissions in the US by 50% by the year 2030, and then getting to net zero by 2050. So these are very robust targets that have been set, but the culture is changing, and then the movement and the energy and the enthusiasm is there.
Well, that's great. We're going to go to audience questions shortly, but I want to just maybe close out with one final question in a sort of different gear, which is, healthcare providers are great communicators with people. You listen to our doctors in a way that maybe people won't listen to me. I'm curious, is there a role for doctors, for healthcare providers to play in informing patients about, what they should be doing for their own health around climate, but also this bigger decarbonization picture. How do you think about those questions? And we could just go very briefly across the line if you have a quick thought.
Yes, and I think that, Justin, as you pointed out, we went into healthcare because we took the Hippocratic Oath of doing no harm. And we know now that the choices we make and the pollution that we generate actually causes the same amount of magnitude of harm as preventable medical errors. So yes, we're very responsible in healthcare to decrease emissions. And then patients, in a free market economy, patients are the consumers. And patients have a lot of power, and this is how cultures change, right? It starts with one patient, and you go to your physician and say, hey, what are you doing to green your practice? And I think that maybe they don't have all the answers, but done in a nimble and a sort of a team way, we can slowly get there. These conversations can help advance.
It's great.
I'm reading Gabor Mate's book, The Myth of Normal, right now, and if it's not on your library list, go there and request it immediately. But I'd just like to pull a quote from that. So, popular outrage, even when it bursts into flame temporarily, does not translate into structural change. Massive public assaults on human health and humane ethics are, for lack of a better word, entirely normalized. It's our sector's responsibility to flip that switch and make it so that these assaults on public health are not normalized.
That's great. Very powerful.
Yeah, I think you just, that's exactly right. We have to say it's just not okay. And you have to understand what's valuable to them, not just what's the matter with them, but what matters to them. Is it their grandchildren? Is it their breathing? Is it the future? Is it short term? Is it the economy? Addressing these issues can address a wide range of problems. And so I think we have to take it on. Healthcare providers, doctors, nurses, pharmacists have to get out of the mindset that just wait until people's sick and then fix them is what your job is. That should not be our job. It should never have been our job. Our job is to keep people healthy, and this is a way to contribute to keeping people healthy. You can empower them to act. You can help them understand how this makes a difference, both short, medium, and long term.
Can I just make a quick point?
Yes.
Justin? And I do, to your point about how do we change the culture, and I read something very beautiful that said, culture is like the breeze. You feel it, you don't see it. Right? And so changing culture is sort of going to happen very slowly. But as someone at sort of the grassroots and front line, I don't want my CEO coming to me and saying, Seema, you need to change this. Mandates are never going to be sort of very palatable, right? So we change culture through sort of one action at a time, basing it on education, collaborative partnership, and again, evidence-based choices.
Well, we have more time now, which is added, which is always excellent. So I think I'll actually ask one more or two questions before we get to, I know you'll be first, you're very eager. So I want to pick up on this point about cultural change though, because this is a huge part of this conversation. How do you get people to think about doing things differently? And I just wondered if you would maybe expand on what you were talking about, Seema, just especially for a doctor, a doctor who maybe has been practicing medicine for a while and is accustomed to certain practices, and all of a sudden you're saying, you need to reuse certain products, you need to think things differently. How do you shift that culture?
So I think that, again, data is our big friend. And we don't have to reinvent the wheel because frankly, we don't have the time to. So looking east, and in this case, the one example that stands out globally is the NHS. So the NHS is the only system in the country right now that mandates reporting, and they track how they're doing, right? Every health system in the NHS has to track what they're doing, collect the data. So I think that that's really important. It's going to help us get where we have to get to. But also in our sort of personal practices and choices that we make, A great paper came out comparing cataract surgery, as we know is one of the most common surgeries done globally, comparing the waste that was generated out of the UK compared to that of India, and a very premier center. And in India, the same cataract surgery produced about 6 kilograms of CO2, while as in the UK, it produced about 130 kilograms of CO2, and in the US, much more than that. So I think looking to where the best practices are, systems that are doing it better than we're doing, taking examples from there is going to be very important to help us get there as fast as we need to. And holding ourselves accountable. That ABCD, the A of accountability, is very important.
So data, examples, that's great. Shanda or Jeff, do you want to come in here? Shanda, maybe?
Yeah, I'd love to jump in. Thank you. In addition to data, I believe that stories change culture. That's how we evolved as humans. And I think if we look at the healthcare sector, it's time to look ourselves in the mirror. And back to your first question, Justin, of I think first or second, related to, is this our lane, basically? Should the healthcare sector be addressing climate change? And what I shared was, our lane is to do no harm and to help people be healthier. Are we really doing that? Are we doing it to the extent that we could and that we should? And if we're not, moving the needle on climate action is a wonderful way that we can help shift the culture of the health sector in a way that will be longitudinally more beneficial for all of us. And telling our stories, having these conversations, thinking about what your role is in this, why do you care about it? The grandchildren and the children was a wonderful example. And so we need both the data and there needs to be the heart in this as well.
Yeah, I'm just disagreeing with Seema on how you change culture. And I believe that it does happen one at a time, but the job of leaders is to set a framework and to build a pathway so that can happen more easily. And so I believe it can't be left to hope or individuals, that leaders have to stand up, and this is one of the advantages that the National Academy bringing people together, the Consortium on Medical Societies, the IHI, being able to do this, putting these groups together, and so leaders look and say, geez, there's all the other people. They're successful at quality, they're successful at education, they're successful at research, and they're leaning in on this. Must be where we're going to go. It fits in with our broad mission statement. This is where, and then declare, this is what it looks like for healthcare to be. So if I'm the CEO of a system, I'm not making it optional that we care about the health and well-being of our patients and our community. It's not an option. And so you want to be in our culture, that's what you're going to be. If you don't want, you can vote with your feet, but in our culture, that's what we're going to be. Now, anesthesia is going to do that differently than pediatrics, than the pharmacy, than the maintenance people will. But they're all going to be united with this single theme, and the more organizations that we have that theme, that'll drive policy, it'll drive the supply chain that is very important, as you pointed out. So I believe it's the responsibility of leadership and boards to take part of this on and say, we have to say, this is a part of our work. We're not going to stay mediocre any longer, and we're just going to have to do this for the good of our population that we serve.
Jeff, I completely agree with you and disagree. I agree to the point that, yes, we need our leaders to be a part of the cultural change, but not just via mandates. To the point that Shanda said is by modeling it. And now that the Joint Commission has said, yes, environmental sustainability is important to us, right? HHS, CMS can work on incentivizing. So I think by modeling it, it sort of snowballs. I think that's very important. And to Shanda's point, we know, we've looked at what motivates people to change culture. And internal motivators and external motivators both have to be balanced together, right? Yeah.
Well, that's great. I think, different models of change are often something I encounter in my reporting, and oftentimes it's a little bit of both. It's a lot of both, maybe, but that's how things change. I think we're ready for audience questions. Is that good? Okay, we'll come here, and then we'll go there. Oh, are there mics? Do we have mics? Okay. We do maybe have mics? Okay.
Well, I've been green before green was a vocabulary word, by what I eat, by how I move. And I'm very upset. We downsized into and these condominiums, at least this one, is very toxic. Every month they clean these elevators with, you can't even breathe. And we complain, we threaten, there's nowhere to call. And there are people who really are getting sick there. So I want to address the chemicals that people use for cleaning, both in the hospitals, because you walk in a hospital, it smells like Lysol, and the chemicals that we inhale living in congregant areas. And I can just add one thing. I work with special needs. I have a learning center. I used to diagnose one child a year with autism. Now I have 20 a week, and I really feel it's all this environmental stuff.
So it's a very important point that we didn't touch on as much as the environmental health impacts of pollutants and things that are co-pollutants of carbon. And anyway, I don't know if anybody wants to touch briefly on that point.
I think what we don't know is the scariest part of all that. If you look at the chemicals that have been invented since World War II, like 12% or something, I don't know, there's so many getting invented all the time, but it's somewhere under 20% have ever been tested for inhaled or carcinogenic toxicity. There is an enormous number of drugs out there. Now, to that, there are ways to clean and to keep your hospital, your community living areas, those things healthy without going to all the most potent chemicals. There are ways to do that, but you have to commit to doing that. So I think you're right, it's an issue, and that it should be addressed. We don't know exactly all the harm that's being done. We don't know the causes of this remarkable rise in autism. As you point out, there's hard data that show that we're diagnosing many more. But while we're waiting to know all the details, there's a whole lot of things that should be done to decrease the risks for people. Thanks for that question.
And along with chemicals, I would like to add plastics, because we know that microplastics are ubiquitous in our water, in our food, in our fish. Right? By 2050, there will be more plastic in the ocean than fish. So I do think that, it comes to policy, it comes to innovation, it comes to working together individually to lean away from single-use devices, right? We can't do it alone. Again, collaborative work on this area.
And the thing about addressing plastics, too, is plastic is a huge contributor to greenhouse gas emissions. So you address public health, you also address the emissions. I was going over there next.
Hi there, I'm Shanda Butler, and speaking of healthy environments, I just want to give a huge plug to the Alliance of Nurses for Healthy Environments, doing a lot of great work on that. And going back to the question where you said, is healthcare, is this really our lane? The climate pledge has really, from HHS, has really focused on, this is a health equity issue. So I would love for, Shanda, if you could go ahead and start on talking about why addressing climate is a health equity issue and why we absolutely have to be in this lane and leaders in the lane.
Amazing question from a fellow nurse, so thank you for that. So many of the places in communities where incinerators, landfills, large municipal entities that deal with the waste coming from healthcare are in marginalized communities. It's been that way for pretty much the duration of of the healthcare sector in the United States. What happens in these communities is folks are facing increased percentages of issues from air pollution, from the direct toxics that are in that environment, and they have less access to health care in the first place. They have perhaps lower levels of education, less support than others that aren't living in those marginalized, highly impacted communities. Part of the reason that I love this question is because health equity has risen to a level of priority in many health systems, and if it's not yet, it will be, just related to reputation and needing to address that across the country. But being able to tie climate action, environmental action more broadly, including toxics, microplastics that are decreasing the impact in those marginalized communities, does help to move the needle on the health equity mission for health systems.
So I think that, at least in our system and in Northern California with the fires and temperatures, we saw that populations that had the least access to care and actually the least contributors to this problem were the most impacted, right? And our EDs were full and patients had access issues because they didn't have the transportation to even get to ED. But these are the same patients who don't have air conditioning in their houses. So yes, that is sort of the premise, is health. This is an equity issue and a big public health crisis.
Okay, great. So we have a question over here.
Hi, I'm Tori Adams, RN, MS, and I'm not embarrassed about my age. I did my basic nursing training in the early 1970s and worked in critical care units during the evolution of the AIDS epidemic and have worked in a public health sector during the COVID epidemic. And I'm interested in your opinion on the changes that I've seen over 40 years, maybe more, in our policies and procedures, starting IVs without gloves, with needles, not having disposable things to take blood gases with, using bottles for IV fluids instead of plastics, etc. Do we need to do that when it's not an epidemic or an unknown thing? I understand that in underdeveloped countries that a lot of their healthcare systems use these, what we would call outdated procedures. And I'm kind of curious about that. And then point B is, as a consumer of healthcare, every time I go into a physician or group practice office that has been rebuilt or updated, what I see are no sinks in the exam rooms. And I'm curious whether there really is data that shows that hand washing with water and water and soap is less good than practitioners using foam and then coming in a room. Thanks.
Want to take that?
Yeah, thank you for that fantastic question, and I'm so glad you asked it. I'll tackle the hand washing one first, because so a lot of this started in the 2000 when the to air, that movement started, right? And what happened is it led to this epidemic of more single-use devices, more gloves. When we know that, yes, infection is related to hand washing, there is good, unequivocal data that hand washing your, how long you scrub, is much better than wearing gloves. In fact, there's data to show that wearing gloves increases infection in some cases. And they've done studies where they put gloves and then people feel like they touch all over because they have gloves. While if you have stuff on your hand, you're less likely to touch it. Again, looking back to the UK, they had a big movement called the gloves off movement. So that answers your question, that hand washing, patient factors, right? You can get as many disposable equipment as you want. But if the patient had diabetes, if the patient has vascular conditions, if the surgeries are going to go on for a really long time, those are the predictors of bad outcome, not just using single-use devices. But we've gotten to this culture, because we are a consumer society. There is also some fear about infection. There is a fear about litigation. And all of this has sort of coalesced together to get us here where we are right now.
My 10-second ad, the manufacturers of single-use devices, which are mostly plastic, is the petrochemicals and fossil fuel industries.
And my 5-second ad is, just like the rest of society, convenience and perceived short-term low cost drives a lot of decisions. Convenience, short-term, I mean, think about probably not all of you, but awful lot of us have made those decisions. We try not to, but that has driven a lot of things. We're trying to get back from that, we're trying to make sense, but it's harder to dig back out of that hole than not digging in the first place.
Okay, so we'll come up here for one probably last question. So, but if you could be relatively brief, that would be great.
Sure.
That was directed at me.
Thank you for your impressive work. I, too, am a medical professional. I'm a registered dietitian and worked in a hospital for years. We know, according to the United Nations, that raising animals to be eaten as food generates more climate-damaging greenhouse gas emissions than the entire transportation sector, and that following a healthy plant-based diet decreases our risks for heart disease, cancer, diabetes, hypertension, and that whole grains, beans, fruits, and vegetables are typically less expensive than meat, dairy, and eggs. What is being done to provide healthy food for patients and staff in medical institutions?
That's a great question.
I can jump in right away for that. One very specific program, if you are in a leadership position in healthcare, it's called the Cool Food Pledge. It's in partnership with the World Resources Institute, and basically it's an initiative that's driving not only hospitals, but multi-industry to institute those plant-forward meals as the default, and helping shift towards the co-benefits of decreasing greenhouse gas emissions from the ag sector towards the health improvements that you referenced. So the Cool Food Pledge, check that out.
What you said is exactly true, backed up by multiple studies, and there are many healthcare organizations who have leaned into that and are making healthy meals, although not without a lot of bumps, for their patients and their staff. And if the organization you're associated with isn't, there's an awful lot of data and help from wonderful organizations like Healthcare Without Harm that can help them move in that direction, because you are absolutely not wrong. It is an enormous impact on our global footprint, the amount of energy that goes into producing meat.
Mm-hmm. And my 10-second add to that is, at least I can speak for my institution at UCSF, we have meatless Mondays. So there is no meat served on Mondays. And then our burger was voted the tastiest burger in San Francisco, but has 30% mushrooms in it. So you're decreasing your emissions even from that. You know, we have plastic straws, no bottled water. So yes, there's a lot that can be done, because food is a big contributor to the emissions in that supply chain that we talked about. Local, sustainable, so that the transportation emissions is decreased. But at a personal level, not wasting and finishing, exactly like I tell my kindergartner.
Well, thank you for this discussion. We only have 30 seconds left, so rather than try to squeeze in one more question, I'm just going to say thank you to all of you. I think that you made the case for the urgency of the health sector getting involved, and thank you to the panelists.
Thank you very much, everyone.